Great. Thank you to the organizing committee for volunteering us to present. My name is James Yu on behalf of Dr. Deb Schrag and the Cancer Treatment Work Group, led by Dr. Yabroff, including Dr. Hank, Dr. Wheeler, Dr. Shi, Dr. Snaldone, and Dr. Halpern. I'll be spending 9 minutes presenting the Health Economics Research Cancer Treatment as well, and Dr. Schrag will spend 6 minutes, and together we'll get through this. These are our conflicts of interest. Apologies, we don't have that much time to go over what was months of free-ranging discussions. If I scramble over words or phrases, I apologize. However, if I scramble over ideas or concepts, please blame that on my clinician's lack of understanding a lot of these complex health economics concepts, but perhaps my co-committee members can weigh in the chat function. We were charged with looking at cancer treatment, and this now ubiquitous health economics research framework kind of puts cancer treatment in the center of everything. I think by now most of us have this tattooed to some part of our body. But the background of treatment, when the work group got together, we thought that health economics research into cancer treatment was a very difficult subject because of the sheer number of types of cancer treatment, and then the almost unlimited number of combinations of new cancer treatments that exist for different cancer sites, stages, molecular characteristics. And these cancer treatments are evolving very, very rapidly. The number of times I've walked into a tumor board and a medical oncologist mentions a new therapeutic that I'd never heard about that's already FDA approved happens all the time. And so the rapidity of these evolving treatments, coupled with the expense of these treatments, makes studying cancer treatment particularly important and particularly difficult. Many of the health economics studies of cancer treatment use existing health insurance claims and electronic health record data. And these data, as many of us are aware, have limitations in terms of relevance and timeliness. Insurance coverage benefit design changes rapidly, often faster than these insurance claims data are able to provide to researchers. The data linkages themselves can provide information about cancer characteristics, but often these are for select populations, for example, enrolled in Medicare fee-for-service. And finally, there are a few prospective economic studies in looking at health economics of cancer treatment, including as part of clinical trials. And that's a need that Dr. Schrag will talk about in the second half of this. Our work group focused largely on data, specifically the unavailability of key measures. We were all very interested in seeing more data on functional and performance status, various molecular data about whether a patient was eligible for certain treatments versus others. We were interested in the key treatment outcomes that are not routinely recorded, such as health-reported quality of life, health-reported quality of life, treatment-specific utility estimates, obviously very difficult to do as treatments change dynamically. We were very interested in why different treatments were chosen, reasons for switching from one treatment to another, dose changes, discontinuation of treatment. We were interested in when cancer recurs, it doesn't recur uniformly. Rather, it can recur in different parts of the body, locally, the primary tumor, metastatic in the brain. We were interested in key survival outcomes beyond survival that perhaps cause specific mortality. And then we were interested in more granularity in patient characteristics beyond, male, female, black, white. We know that people are much more diverse than those dichotomies. And finally, we were interested in non-medical economic data, financial distress, food and housing insecurity, productivity loss. And we were also interested in more granular provider characteristics beyond what is captured in, for example, the AMA master files. So in addition to a need for more data in general, we were interested in more comprehensive data. Typically, data is defined by a geography, age, and insurance coverage type, but changes in insurance coverage are also informative. For example, transitions in coverage can be meaningful. A switch to disability could, obviously is a meaningful outcome in and of itself. Or if a patient becomes unemployed due to cancer, they would lose their health insurance coverage and perhaps their data would be lost. And knowing that median enrollment for Medicaid is only 8 months, changing from Medicaid to another insurance coverage provider would obviously be helpful in maintaining a more longitudinal understanding of that patient. And caregiving data is largely absent from EHR or health claims data. And that's obviously a critical part of a patient's ultimate outcome from treatment. Finally, as cancer changes rapidly, timeliness is critical. Data that is 2 years old or 3 years old is not relevant to modern treatment decision-making. And the lack of this real-time data means it's harder to inform policy and practice and to have truly a learning healthcare system. There are more timely data sets. Perhaps your own institutional data sets are even, as of yesterday, timely. But whether that data is representative of cancer care nationally is also an open question. So there are trade-offs between timeliness and representativeness. So that's data in about 6 minutes. In the next minute and a half, we'll talk about what we felt were the training needs for clinicians interested in health economics research in treatment. Obviously, the clinicians spend a lot of time in the middle of that cancer continuum, but don't often understand the economic inputs and structural factors and the ways to measure societal and patient level, frankly, outcomes of cancer treatment. And the work group felt that meetings and seminars in general would be the most helpful and perhaps most cost-effective way of increasing collaboration, because otherwise training intensity would potentially require fellowship level training or K awards or MPH programs, frankly, for clinicians to learn health economics research, the economic side. For health services researchers and economists, it's the middle of this, the framework that's more difficult. Cancer treatment is changing day to day, and I'm thinking to the last question of the last session of the liquid biopsies. As we push forward into the future, perhaps partnering with clinicians, which is, I think, one of the major goals of this workshop, it would be the best way to move forward, given how rapidly everything's changing. And finally, other opportunities for collaboration, like this meeting, and kudos to the NCI and the organizers for putting this together. But there's also potential partnerships within cooperative groups, the Cancer Care Delivery Research Committees, professional organizations like ASCO, Academy of Health, and perhaps within the major clinical data sets, including more economic data, is a potential way to increase collaboration. And with that, we'll move on to Dr. Schrag's side.
Thanks so much, James. So I'm just going to close this out with a few comments on one specific aspect of treatment data, which is the effort to try to get information alongside clinical trials. So everyone knows clinical trials are, randomized trials still offer the most unbiased estimate of whether a treatment can work, and they really are answering the efficacy questions. But they do give an opportunity to figure out the incremental value of a new treatment and what it costs to deliver that treatment. Next slide. James, can you advance? Great. Integrating economic analyses alongside RCTs was addressed in a really beautiful monograph. Authors are not listed. This is a monograph from 1998. It's from NCI authors. I have a sneaking suspicion that Joe Lipscomb, whose name I see somewhere listed here, is an author. So maybe Joe could speak up and take credit for this. Is really, it's an old paper, but it's a good one. And it addresses whether or not an economic analysis makes sense alongside an RCT, and provides a really helpful framework for trying to answer this question. And in the early aughts, that was something that was considered. As a matter of fact, for a while, it was policy that every RCT that came through the cooperative groups used this framework to decide up or down whether or not a companion should be integrated. But it was really hard to get funding for these companions. Next slide. So we have so many trials now, particularly done in the cooperative groups, that look somewhat like the schema for this bladder cancer trial that came through one of the cooperative groups last spring. Essentially, all these trials are asking less of versus more of some chemotherapy. So in this one, it's Arm A is continuing the immunotherapy and Arm B is stopping the immunotherapy. But of course, it's possible that downstream, there'll be some crossover and patients in Arm B will go on to get more immunotherapy out the back end. So there are real potential economic consequences here, given how expensive immunotherapy is. So an example of a case where, according to that 1998 framework, an economic companion might make sense. Next slide. Unfortunately, the current reality is that it's just no longer feasible to integrate economic companions alongside clinical trials because there's no mechanism. So investigators tried to integrate one in this one, but the feedback they received, and I would say, you know, this is after maybe 80 hours of work developing the companion, basically inclusion of health economics and healthcare utilization should be deleted from the protocol. Neither CTEP nor DCP provides funding for these studies, and alternative mechanisms through NCI also not available. And this happens repetitively, and for the most part, this endeavor has been abandoned. Next slide. We do have some tools. They're languishing, mostly unused, to get good economic data. For example, on things like indirect costs. This is a snip of a survey that asks patients about their indirect medical costs. It gives everyone a standard survey at a couple of time points to get their caregiving costs, transportation costs, out-of-pocket costs. They're not super high burden. The tools exist. The wheel doesn't need to be reinvented. Next slide. So this is kind of a thought exercise. This is a workshop. Why not be bold? What would transform the ability to evaluate the economics of cancer treatment prospectively to collect data alongside clinical trials? So I think it's helpful to break it down depending on what the fundamental research question is. So in the left-hand column, I put some of the fundamental research questions that we need answered. What's the ICER of treatment A versus treatment B? The transformational intervention to answer that flavor of question would be to provide a clear mechanism to support integration of economic analyses alongside clinical trials. Another key question is, what does it cost the health system to deliver one unit, let's call it a month, a year, or a typical course of the treatment? And it would be pretty straightforward to develop standard methods that facilitate comparisons across treatments, because it's really not possible to get this kind of a cost menu. One could imagine that if you had these standardized units, treatments would be comparable in league tables. And maybe it's a fantasy, I'd be curious what others think, but you might even imagine that this could exert some downstream pressure on prices. What does it cost the patient to obtain 1 unit of a typical course of treatment, whether it's a month or a year, in terms of the time that is required? Is this weekly Taxol that can be given over 30 minutes, or is it 10 hours, you know, at a time every 2 weeks for CAR T-cell? What does it cost the patient in terms of out-of-pocket costs? What does it cost society? And how do these economic factors influence treatment outcomes? So I think that there's room for improvement. There are potentially transformational interventions, but there are some structural barriers and obstacles in the way. But a lot of thought has already been invested in this field, and we shouldn't need to reinvent the wheel. And those who ignore history are doomed to repeat it, I would say. And I'll stop there. Thank you.